Tell Me More podcast is being recorded on the lands of the Wurundjeri people of the Kulin Nation. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander cultures. Welcome to Tell Me More, where we have conversations about the good, the bad and the real. I'm your host, Olivia Molly Rogers. Today's episode feels really special to me because it isn't just something that I'm curious about, it is something that I have experienced. Back in 2022, I saw Dr Raelia Lew for fertility treatment. And then when I was single at 31, I decided to freeze my eggs. That experience brought up so many emotions and questions that I didn't really expect. Raelia helped me so much during that time, and I know so many of you have those same feelings and confusion about timing, fertility, and choice. So today we're talking openly about it all with your questions as our guide. Raelia, thank you so much for joining me. It's so special to have you here in the studio.
Thank you for having me. I'm excited to be here.
Now, we met back in 2022 when I came to you for some treatment. And then I saw you again in 2023 when I froze my eggs. And I think you're amazing at what you do. And you made me feel so at ease. And I think you're the perfect person to answer these questions that we have because my audience sent through so many. It is definitely a hot topic with my audience. So yeah, I really appreciate you being here. I would love for you to start by telling me how you would describe what you do to a stranger.
I am a fertility doctor, and that makes me a baby maker, principally, first and foremost, but I'm also a problem solver. I help people navigate their fertility journey, whether they're ready to have a child, whether they're planning for their future, whether they're struggling, and hopefully I help them. I always joke that I have a huge carbon footprint because I've brought thousands of babies into the world professionally.
That's a good reason to have a big carbon footprint, I think. Yeah. Now, I have tried to sort of categorize these questions because there were hundreds of questions, a lot of them very specific, and so I'll try and keep it more broad. But starting with the first thing, I think really relevant for the reason I came and froze my eggs with you is I was 31 and I had just come out of a long-term relationship, and I really worried that maybe a baby wasn't in my future. And I wanted to sort of secure it in a way because I didn't want to meet someone and then rush into having a child within a year or something just because I really wanted a baby, because after being burned, you also want to make sure that the person you have a child is the right person. And I don't think you really know that until you've been with someone for, longer than a year, that's for sure. What do you think about someone who, a lot of people have said, what would you say to someone who has just come out of a relationship and feels the need to make a decision right now about that?
What I would say is that egg freezing is an amazing technology that is very accessible. It's proven, and it is capable of buying us a little bit of time. Obviously, it's not fail safe. There are some people, unfortunately, who have frozen eggs and subsequently have relied on them and not been successful. But with today's technology, we're able to honestly and transparently say that if a young woman in her early to mid-30s freezes a high number of eggs, then we are very certain that she has a very high chance of being ultimately successful in having a baby. And the majority of women who do that will ultimately be successful. There'll be some people who freeze their eggs and ultimately don't need to use them at all because they may still have plenty of fertile time ahead of them, and they may be able to conceive naturally. But I can tell you that at Melbourne IVF, where I'm currently medical director, we have created more than 400 babies using frozen eggs.
Wow.
And every week I'm seeing women come back to use their eggs. And I would say that in 2025, I've had more patients return to use their eggs than in any other year.
Really?
And I started freezing eggs at Melbourne IVF in 2015.
Oh, that's so interesting.
It's been a decade.
Why do you think that is, that there's more this year than any other year?
I think it's because of what has happened with egg freezing over the last decade. In 2012, the American Society of Reproductive Medicine and the European Society equivalent, ESHRE, both came out with statements that egg freezing was at that point considered non-experimental. Up until that point, people had been freezing eggs in the context of cancer treatment when someone had a dire cancer diagnosis and needed to have therapy like chemotherapy or radiation therapy that we knew might compromise their future fertility seriously. And so we froze eggs, even though the first egg was frozen, I believe, in 1983. So in terms of being subsequently utilised to have a child. So we've been freezing eggs for a really long time, but at that 2012 time point, we had enough data to say, hey, this is actually something that can be mainstreamed, that it doesn't have to be confined to experimental therapies, that actually, yes, it does work. And so people started uptaking egg freezing in terms of mainstream medicine electively. And so we've seen more and more women freeze their eggs, and we've seen a 400-fold increase in women freezing their eggs over the past 5 years. So it makes sense that as more women have elected to freeze their eggs, that more women are returning to use them. So I actually think the second chapter of the egg freezing story is yet untold and unwritten, and that we're going to see over the next decade a significant change in behaviour and patterns.
Have you seen more women coming back to do it on their own?
I have, and not only on their own for a first child, but on their own for more than one baby.
Oh, wow.
Yeah, and I've also seen women who I froze eggs for a decade ago or abouts, who had children naturally and have come back to use their frozen eggs to have a third child.
Oh, wow.
Where they otherwise might not have been able to because now they're in their mid-40s.
And I remember you said to me, there was a calculator that sort of told you the likelihood, or it told you the likelihood of your age and the number of eggs you might retrieve, and then how many babies you're likely to have based on that amount. And I can't remember like how it worked exactly, but I remember you putting in my age at the time versus my age in 4 years' time. And the percentage was so much higher with my younger eggs. Can you explain that?
Absolutely. And we've actually updated a calculator now with Australian data. So the calculator I showed you a few years ago was using American data, but there's actually a new calculator on a new website called Egg Freezing Australia that uses a combination of Australian data and worldwide data, so a bigger pool of data that is even more accurate. And what it does is it basically looks at age as a parameter, because we always say in IVF, age is queen. You know, age is the most important prognostic factor in fertility, natural and with assistance. So we pop age in as an egg quality measure, and then we look at the probability of having a baby from a frozen egg, and we can then move a dial to enter a number that represents the eggs that we either aspire to freeze or have frozen so far, and we can calculate the probability of having 1 or 2 children on the calculator.
Yeah.
So for someone in their early 30s, the probability of having 1 baby can be taken up to and above 90% if they freeze 20 eggs. And if you are a bit older, you do need to freeze more eggs to hit those stats.
But it's harder to get more eggs to freeze, right?
That's right. It's one of those things that in parallel, we experience as we get older a decline in our ovarian reserve, so we can't make as many eggs in a cycle. And in parallel to that, our egg quality declines as well, and the propensity of an egg to make a baby declines. So we need more eggs and they're harder to get. So it is much more cost-effective, time-effective, and just effective to freeze eggs when you're a bit younger.
But how young is too young? Because I had quite a few 25-year-olds messaging me saying they're already thinking about it, but then they're like, what if it's just a bit of a waste of my money? Like, am I too young to even consider it? What do you think about that?
It's really interesting. I think the younger you are when you freeze your eggs in a way, the less likely you are to need to use them just because you have more fertile time ahead of you. But at the same time, a lot of research shows that women who do freeze their eggs think about it for over 2 years before they do it. So I think it's good that 25-year-olds are thinking about it, not necessarily pressing the go button just yet. But I think it's good that they're thinking about it, because I think around the age of 30, in your late 20s/early 30s is the sweet spot, because you know where you're at in life up to that point, and you can project forward as to whether you'll have a baby in the next couple of years. So I think women are the best judge of whether they should freeze their eggs or not. I don't think people do it lightly or flippantly. I think they think about it a lot. And the earlier that you contemplate it, the more likely you are, if you do proceed, to choose to do that at an age that's really biologically relevant. So I think it's good that people are thinking about it. Hopefully they're not stressing too much about it.
Yeah. I think that's the thing that I was reading that thinking, God, I don't think I thought about that at all when I was 25. I know I've wanted to have babies since I was a baby. Like I used to walk around with a baby toy all the time. Like I know that I've wanted that forever, but I don't think at 25 I was worried about that just yet. But I guess we see so much more now publicly about people who struggle with fertility that maybe it's just seeing it in your face more makes you more concerned about it.
And I just think women are more educated about our bodies, and I think that's a good thing.
Yeah, definitely. And I think the fact that more people are willing to have babies on their own and talk about that, because that's definitely why I came to you as well to freeze my eggs, because I thought I'd rather freeze my eggs, have the option down the track to get a sperm donor if I decide to do that, because I knew that I wanted to be a mum more than anything. And I wasn't willing to end up with the wrong person again. And I thought, I think every woman is better off doing it on their own than with the wrong partner, personally. Do you agree with that?
I think that there are now so many different ways that families can be formed. I do see that it is really very challenging and so brave when women make that decision to be a solo parent. They do need to build their village of support because they don't have that built-in support of a partner in their domestic relationship. But it is socially acceptable. People do it. People do a great job of it. And, you know, I know so many people who have split up from their partner and none of them regret having their children. And, certainly there are so many relationships that can be abusive. There are, you know, very difficult circumstances for children to grow up in relationships. So I don't think it's necessarily anyone's first choice to have a baby with a sperm donor, but I don't think women should miss out on motherhood because of circumstances outside of their control.
A lot of people wrote in about AMH tests. Can you explain what that actually means, why we should be testing that, and are there any other things that we can test before we sort of go down any kind of fertility path?
The first thing I'll say about AMH is what it is, so that people understand what it is, because once we understand what it is, we can also understand what it isn't. So AMH is a hormone that is made by follicles in the ovary, and it's a proxy measure of how many follicles there are in the ovary, because if a follicle makes a certain amount of AMH, then the total amount of AMH in the blood is going to represent the size of the ovary. Bigger ovaries will make more AMH because they'll have more follicles, and smaller ovaries won't make as much AMH. And most things in human biology are what we call normally distributed, which means there's like a bell curve of what is normal, and there's not one normal value. There's a range of what is normal. And you know, I often with patients, I use bra size as something that girls get, because you can have an A cup and be normal, and you can have a D cup and be normal, and everything in between is also normal, but it's different and unique. And that is a little bit like ovaries. They're a different kind of endocrine gland. You know, breast is endocrine gland, ovary is endocrine gland. And you can have a bigger ovary and you can have a smaller ovary and still be normal. So women with a bigger ovary and more eggs left at that stage in life will have a higher AMH when we measure it. A woman with a smaller ovary will have a lower AMH, and there's a range of everything in between. In our natural menstrual cycle, every month, most women release one egg, regardless of how many other eggs they have. So it's very possible to be very fertile. If you're young, if you're well, and you just have a slightly smaller ovary, you're the A cup of the ovary, you can be really fertile. It doesn't mean you're going to have trouble getting pregnant. You might have a regular menstrual cycle. You must release one egg a month to get pregnant. You might release one really good little perfect egg. And so AMH doesn't mean if it's low that you're infertile.
That's really good to hear that, because I feel like that's not necessarily the messaging that people have been told.
It's one of those circumstances in terms of fertility that no one factor is critical, but when we take the full picture of where a person is in their life, what the projected pattern might be for them in the future, and what all of the variables that come together to make that circumstances are for them, it helps us understand the relevance of each individual factor. When it comes to AMH and egg number, what it does predict is how many eggs someone might be able to make in a cycle, where we try and give them medicine to make them make as many eggs as they can. So someone with a lower AMH who's thinking about freezing their eggs, or if they're trying to have a baby, need help and are doing an IVF cycle, the number of eggs that they're going to be able to make in a month is going to be limited to how many follicles are there. We always say you can't stimulate a follicle that isn't there. You have to work with what you've got. So in terms of IVF and in terms of egg freezing, someone with a nice AMH level, an average AMH level, might be able to produce something like 10 to 12 eggs at an egg collection. And if your AMH level is a bit higher, you may even be able to make more eggs in an egg collection. And when we advise to freeze 20 to 30 eggs, what that means to an individual is they may be able to achieve that in a reduced number of egg collections. Most women who freeze their eggs do 2 egg collections. The average person, the B to C cup, shall we say, would do 2 egg collections to get 20 to 30 eggs to the freezer. Some people can get that in 1, but that's a real outlier result.
Okay.
Most people would take 2 if there's nothing wrong with them and they're average. If you have a really low AMH and a petite ovary, it may take you more. And that has impacts on, firstly, the burden of treatment in terms of the physical, the emotional, the duration, the cost, everything. And it also means that in terms of IVF, if we're trying to help someone have a baby because they have other things going on and it's tricky for them, the chance of making a good embryo in 1 round is going to be relative to the number of eggs we have in play. Because in IVF, what we see is that not every egg that we find is a perfect egg, and not every egg will fertilise and do all the right things it needs to do to make an embryo, let alone a baby. So the more eggs you have, the better your chance. So I would say that AMH, and potentially why people get a little bit scared and frightened if they have a low AMH, it is a negative prognostic factor when someone has infertility and is doing IVF for those numerical reasons.
Okay. Are there other tests that we can do alongside testing for AMH that aren't too invasive or too expensive?
We can test for really, I guess, general gynecological health in some ways. We can do a pelvic ultrasound and have a look at the structures of the female reproductive system in quite a lot of detail. We can check that fallopian tubes are open by ultrasound and tubal flushing. We can check the egg count in another way by imaging. So we can do something called an antral follicle count, which looks at the number of little follicles you can visually see on the ovary when you do an ultrasound. And the best time to do that, to be most accurate, is just after a menstrual period. So that's generally when we say to do it. There's no external test of egg quality. So that's why age is that proxy measure. And of course it's true, because it's true for everything, that not every human is going to be totally equal in terms of their egg quality at the same age.
Yeah.
So we don't really have a test of quality. We have a test of quantity when we talk about AMH.
Is there a cutoff age when it comes to egg freezing? Like, will you turn away anybody?
It's a really good question. I saw a patient only yesterday who was 39 who came to me to talk about egg freezing, and she'd been thinking about it for a long time, and she'd actually seen another specialist a few years earlier to talk about it and had been frightened of doing it. And so she came to me at 39 with a pretty good understanding, because she'd had quite a lot of counselling and she'd done a lot of her own research as well. And, the conversation I said to her, or what I discussed with her, is that egg freezing is very good science, but what goes into the freezer is going to be what comes out when we come to use eggs. At 38, 39, egg quality is already impaired. Not to say that many women in their late 30s don't get pregnant naturally and have babies, they do. But the risk of things like having a miscarriage or having a chromosome error in an egg is much, much higher than if you were younger. Also, from the point of view of the egg, we've got to respect that an egg is a cell, and it's a cell of our body that we made when we were a fetus. So when it's been waiting a really long time before we use it, from its metabolism perspective, it's used up a lot of its resources. And so when we subject it to freezing and warming, which from its perspective is a minor trauma, it's not something that the egg wishes to go through. It's something we are able to do that's very artificial. It's more likely to be impaired by that process than if it's young and robust.
So from the amount that you're able to freeze, if you are older, you're less likely to actually be able to use them.
Well, you'll be able to try and use them, but they're less likely to translate to an outcome.
Okay.
So what I said to this particular patient is really, I don't want you to have decision or regret. I always start a conversation without being pushy about it, because it's not my place. But I always start a conversation saying, okay, if we didn't freeze your eggs, would you be ready to have a baby now as a single mum by choice? And would you want to have a conversation about going down a donor pathway? And if they say yes, and quite often it's not a yes or a no, it's a kind of, there's consternation and there's reservation. So yes, people want to know more, but they're not really necessarily ready to take that jump. So I had a chat about that, and I basically said, I'm not going to, shove it down your throat. We shouldn't go down donor if you don't want to, but if you want to, please talk to me about it and I can help you. And then I said to her, look, what we can do is create a resource for you of eggs as they are now, and what we can't do is give you a guarantee of future success and having a future live birth. The best thing we can do, if we're not going to try and get you pregnant right now, is freeze as many eggs as we possibly can, or freeze as many as you feel you want to. We won't get a perfect number, because at 38, 39, it's pretty hard to get a perfect number. If I want a 90% probability of live birth, I've got to freeze about 50 eggs. And remembering that women...
For that age?
Yeah.
Okay.
And remembering that women at that age can't make as many eggs as when we were younger. So they might be in a situation where we do a cycle, we might get 5 to 10 eggs, and that's a good result.
Yeah.
So to get 50, you might have to do 10 cycles, which is unrealistic.
Because you've got to pay the full amount every time as well, don't you?
Unless there's a medical factor, then yes. So it's just unrealistic and unachievable. So we're not going to be able to be perfect. So it's one of those things. The conversation is very different.
Yeah.
Because the options that lie ahead are very different and more limited at an older age.
Yeah, definitely. Now, there was a lot that came alongside the process, a lot of emotions, I think probably more than I expected. I think I went in feeling quite empowered with my decision and kind of excited by it, because I was like, okay, this feels like a good plan. And when we started, and I think it would be really helpful if we can talk about the actual process itself, but you told me that there was mandatory counselling And I was like, oh yeah, like that's a good idea, but I don't know if I really need that. And I went into my session thinking I'll be fine. I had actually just done my makeup because I was about to go to an event after. And so I was going to jump on the call and then go to this thing. And I ended up crying so much, cried my whole face off. And I wasn't expecting it. I think so much more came up for me than what I expected. So can you talk to me please about what the process actually looks like, how long it takes? For anyone who's listening who actually has thought about egg freezing but has no idea what it looks like.
So what egg freezing really is in terms of the clinical is about 2 weeks of medication, and that's to prepare you for an egg retrieval. But before you get started, what we need to do is teach you the logistics, make sure that you have the resources to support you, and that's where counselling can come into it. It's one of those things, counselling in IVF is considered mandatory for anyone who's trying to get pregnant.
Yeah.
Strictly, the legal requirements are not there for egg freezing, but it's available. And currently, we've moved away from it being absolutely forced and mandatory, but it's available for anyone who would like to have it. And it's, I think, helpful.
I thought it was so helpful. I think it made me realize how emotional I was about it, which I think that was really, I had to dig a bit deeper to see that. And if I hadn't had that session, then I think during the process I would have found it really confronting.
And I think those emotions are amplified by the hormones that you're exposed to during treatment. So if you don't contemplate these things beforehand and they just come up during your treatment, you can be less prepared to deal with them.
Yeah, it was a bit of an emotional roller coaster. Yeah.
I think a lot of women don't think about it necessarily upfront, but you can very logically appreciate that when we have one ovulation of one egg and then we have our period, we can feel pretty emotional. So if we ask you to make 10 times that amount of hormone in one go, and then you go to a higher peak of estrogen and then you have a higher peak of progesterone and a higher fall, so it's the drop is profound. Actually, quite a lot of people find that it's not so much during their treatment but afterwards that they feel very emotionally vulnerable.
I've like a hormone crash, and that was quite intense. During it, I was very teary. I also experienced a lot of anger towards men because I was like, this is bullshit. I'm spending all this money, injecting myself, putting myself through so much pain and emotional angst. And I'm like, it's so easy for them. Like, they can just go and, produce some sperm quite easily and go and freeze that. And it seems so easy. I know it's not for every single man, but for the majority. And what women have to go through is so intense. And it just also made me feel so much empathy for women who go through it through any kind of fertility treatment, because it feels quite isolating. I think the support that you provide is amazing, but when you're a single person doing it at home by yourself, spending the money on your own, it just brought up a lot of anger for me.
And there's actually a Medicare rebate for sperm freezing.
Oh, of course there is. Why is it like this? It's just, it just feels so unfair, because then it's also the women who are the ones who have to then carry the child. We just have to go through so much more, and it makes me mad. But yeah, I think you had told me that it was likely that I would experience that, but I think having these conversations are important so that women can really know what to expect. And then they might not, you said you might feel fine. And I think some women do. I've had friends who've done it who didn't experience any of the wild emotions that I did. But I think it's good to know that you might. Yeah.
Absolutely.
So then when you start, I remember, I had the counselling. This was now over 2 years ago, so I'm a little rusty on my memory, but
you would have had a nurse education session.
Yes.
Usually, because when I speak to my patients, I'll go through things like the medical side of things, medical risks and what to expect, kind of as a, helicopter view. And then my nurses are really great at going through kind of the nitty-gritty of what you specifically need to do on what day and how to give what medication when, and making sure that you basically don't stuff it up, because there's kind of a couple of different medications that are really important in egg freezing. One is to stop you from ovulating prematurely. So that's really important. And that nowadays, actually, I can't remember exactly what I prescribed for you, but I think when you froze your eggs, I was mainly prescribing what's called a GnRH antagonist medicine to stop you from ovulating, which is a needle. Over the last few years, there's been a lot of research supporting using oral progesterone for that, which means that you can at least reduce the needles a little bit. And it does reduce cost a little bit as well for women who are freezing their eggs who have to pay for medication, because unless there's a Medicare indication and a Medicare rebate, another cost of egg freezing is the medication. And so that medication is every day, and it has to be taken at the same time so that you don't release all the eggs, because that would mean that you ovulate them and we can't go and get them. So that's important. One of the medications is follicle stimulating hormone. It does come in many different forms, but basically that's to stimulate the follicles of the ovary to try and get the eggs to ripen. And then the last medication is probably the most stressful, I feel, which is the trigger. And that is because it has to be given at a very specific time. And so it's a lot of build up to it. And that medication's job is to start the cascade that would ultimately result in ovulation. And we time egg retrieval so that we've got a couple of hours before you would ovulate, where we go in and get the eggs. And that's because that trigger, which is basically a simulation of the natural ovulation surge that people might be familiar with, that happens in a menstrual cycle. Certainly people who are trying to get pregnant will be familiar with it, because when people try and have sex to get pregnant, they often do what's called ovulation predictor kits, which is looking for that surge of luteinizing hormone that happens, and you can detect it in the urine. But we actually need that same surge to happen after an IVF cycle or an egg freezing cycle once the follicles are ready to go, because its job in the body is to get the eggs to mature.
Yeah.
Because the eggs, it's really interesting. It might be too much technical detail, so stop me if I'm going into too much. But basically our eggs, they're very special cells. Only eggs and sperm undergo a process called meiosis. And that's because most cells in our body have a copy of a chromosome that our mum gave us and our dad gave us from the sperm and from the egg. And we have a whole heap of chromosomes, but we've got 2 of everything. And when we make a baby, we only want to give 1 of everything, because the other half comes from the other person. So we have to, as an egg, go from a cell that has a double set of DNA to a single set of DNA. And so the egg undergoes cell divisions. But the egg is a super special cell. So if you think of the egg's stem cell that makes the egg, it actually, 1 stem cell results in 1 egg, whereas the stem cell that makes a sperm, 1 stem cell results in 4 sperm. So basically what the sperm cell does is it photocopies the DNA that it has, which is like a copy of every gene from each parent. And then, so it's got kind of 2 copies and it kind of becomes 4 copies. And then it splits off into 4 cells so that each of them has 1 copy of everything. With the egg, it's the largest cell in the human body. It has to make an embryo. So it wants to retain all of its nutrients. It wants to retain all of its metabolic resources, all of its cellular machinery. It doesn't want to split off into 4. So what it does is it kind of chucks out discrete packages of DNA. And so the egg starts off with that 4 times of DNA that it's going to give to a baby. It doubles what it's got. So it had 2 copies of everything, it doubles it. And then it arrests. And that happens when we're about 20 weeks pregnant. Like the fetus at 20 weeks gestation will then arrest. And that's in the first part of what this cell division is called meiosis 1. And then that process only starts again during the cycle. So the trigger restarts it. So unless you restart that process, the egg's not going to mature and it's not going to kick out the extra DNA, and it has to do that in order to make a baby. So the trigger is really important, and it also has a second action, which is getting the egg to release from being kind of nestled in the cell wall of the follicle to being free floating in the follicle. So imagine it's like if it's a spaceship and it's one of these little kind of like extra little explorer ships, it's got to kind of launch that explorer ship. So the egg has to separate from the wall of the follicle in the ovary so that we can aspirate it when we go to do an egg collection. So the trigger is really important. And if you don't give it at the right time, if you give it too early, then it means you might ovulate by the time you get to your egg collection. If you give it too late, it might mean that the egg hasn't completed its maturation process before you can collect it. So the timing's really important. So I think that's a pretty stressful one.
Yeah, and because of that, there was lots of tracking. So I had internal ultrasounds. Sometimes when I look back on the egg freezing, I confuse, because I went through IUI beforehand, the year before. So I think my memories are muddled. But I do feel like the process was actually quite similar, except, and you can correct me if I'm wrong, that with IUI we were trying to make sure that I was going to release an egg or maybe two. I remember you saying we don't want more than two because we don't want a litter, but we were aiming for one or two, whereas with the egg freezing we were trying to get as many as possible. So that was the main difference, I think, but I feel like there was lots of tracking for both processes to see where we were at.
Yeah, both processes, it's similar in that the end point of both is kind of ovulation. I guess with IUI, the end point is whether there's a pregnancy.
Yeah.
But in terms of what you go through in the treatment, the last thing that we want to monitor is the timing of ovulation.
Yeah.
And I guess egg collection in IVF or egg freezing is analogous to ovulation. So it's just that instead of releasing the eggs, we go get them.
Yeah.
So the monitoring up to that point is to see when you're going to be ready, and it's very similar as to what you need to do. You'd come in for ultrasounds. Occasionally we ask you to do a blood test.
Yeah.
Yeah. Probably less likely to be asked to do a blood test with egg freezing, but
yeah,
because we're not timing pregnancy, so we don't measure hormones like progesterone and things like that.
That makes sense. Okay, so my memory of blood testing was from the IUI. Now, when it comes to the actual egg retrieval, can you talk about that? A lot of people were asking, is it painful? Do you go under? Lots of questions about that.
Yeah. So look, egg retrieval is an interventional radiology type of procedure rather than a surgery. I always say that to patients. We do, in my practice, tend to use sedation as an anesthetic. It's not a general anesthetic, but what sedation does is it makes you really sleepy, so you don't remember a thing and you don't feel any pain during the procedure. And it feels like it's over in a very short period of time from when you go to sleep to when it's all done. In reality, it takes about 20 minutes. Usually each ovary is drained in about 10 minutes. What I do is I use an ultrasound probe and I pressure the ovary so that it's pressed against the wall of the vagina. And the wall of the vagina is actually super thin. It's got a little muscle layer, but it's very thin. And I use a tiny needle. It's 17 gauge at the tip. And what that means is that it's kind of like the same type of needle that you might have for a blood test. So it's very fine. And that needle is on an ultrasound guide, and I use it to pop the little tip of the needle into the ovary and aspirate, so it's a suction system, the fluid from the ovary. What a lot of people don't understand is that eggs are microscopic. So we literally cannot see an egg with the human eye.
I know when you're talking about it, I'm picturing like a chicken egg, but they're
tiny.
They're really not that.
They're big for a cell, but they're still tiny. So what I am watching on the TV monitor when I'm aspirating follicles is really a follicle kind of shrinking around my needle. And I look at there's like a little tubing system, and I can see the fluid running from the follicle into the tube, which is under a kind of vacuum. So when the follicle's empty, the tube stops dripping and I know it's empty. And I also get that feedback from the monitor because I can see that it's empty. I kind of feel like, you know, the video games I used to play when I was a young child were good training for egg collection.
For aiming and firing.
Yeah, exactly. Wow. Exactly.
It is amazing that you are able to do that with something that is so tiny. And so do you take it all out at the same time?
Yeah. So what I actually aim to do is make as few punctures to the ovary as possible with a needle because I don't want the ovary to bleed or be traumatized.
Yeah.
So usually what I do is I enter the ovary, I aspirate the first and closest follicle, and I manipulate the needle without taking it out again into the next follicle. Right. And usually because the follicles kind of shrink around the needle as the fluid empties, that draws the next follicle closer to the needle. So, and you get very good at it. It's a little bit like driving a car. You know, when you first learn to drive a car, you've got to think about everything. But then once you get really good at it, it's kind of second nature. Yeah. So for me, egg collection is a bit like that. For me, it's super easy. And I generally find that it's very, very safe. It's very unusual for someone to have a complication from an egg collection. It can happen. And because I've done literally thousands and thousands of them, I would say well in excess of 10,000. I've lost count.
Wow.
But, kind of probably I'm going to show my age, but more than 15 years of doing this, I have had maybe 2 patients need to be admitted to hospital for a serious problem after an egg collection related to the surgery, where they've had a big bleed or where they've had an infection. It's very uncommon. Most of the time, things are very straightforward.
And the aftercare, I felt, was really great. Like there were lots of check-ins, and I did experience quite a lot of pain, but I took some pain medication and had a heat pack and just made sure that I rested a lot, and then it was fine.
The ovaries are a tender area of the body. And, I don't know if you've ever had a really painful ovulation, but sometimes even when you release an egg naturally, you can bleed a little bit from where that egg was released, and it can be really quite sore and tender. And after an egg collection, you do have multiple follicles that are a little bit sore and tender. And as a general rule, the better you do, the worse you feel. So if someone has a really kind of quite good egg collection, they'll probably feel a bit worse. And if someone has, this is just as a general rule, if someone has fewer follicles, they will have had less trauma to the ovary just because fewer follicles were drained, and they'll probably find the recovery a little bit easier.
Yeah, that makes sense.
And it's a little bit also that the ovary oozes, everybody's ovary oozes a tiny little bit of blood after an egg collection, just like you ooze a little bit from a blood test. Blood in the pelvis is really irritating. It causes pain. And so if somebody has a little bit more bleeding after an egg collection, then they might be a bit sore for a little while as well.
What are the chances of a frozen embryo resulting in a live birth versus frozen eggs?
Yeah, that's a question I get a lot. So it's a really common question. It's a little bit tricky to compare the two because when we make an embryo, we fertilize an egg and we culture it for roughly a week, 5 days to 7 days. And so when we put back an egg, it's got to firstly thaw, then it's got to be fertilized correctly, then it's got to do a lot of cell divisions to get to be an embryo. And roughly 1 in 5 eggs will make an embryo. So if you go entity for entity, an embryo is going to sure do better than an egg. Because not every egg is going to make an embryo. And when we put an embryo back in IVF, it's as a what we call blastocyst. So it's got about 200 plus cells, and they're all stem cells that can go on and make a human. If you freeze enough eggs to statistically make the same number of embryos, you'll have the same probability of success. It's just that you're not comparing like for like.
Yeah.
So the right thing is to say, you've got to freeze, when you freeze eggs, you've got to freeze enough eggs. And when we're doing those calculations, we're taking into account that not every egg's going to make an embryo. To answer your question of what's the chance of an embryo making a baby, it depends. If you're younger, it's going to be better. And if you're older, it's not going to be as good. So if you look at the most recent Australian data, and we're super proud at Melbourne IVF to punch above the Australian averages by quite a bit. But let's look at the averages. Your chance of an embryo making a baby in your early 20s is going to be about 1 in 2. Your chance of an embryo making a baby in your early 30s is going to be about 1 in 3. Your chance in your late 30s is going to be about 1 in 4. And your chance in your 40s is going to be no better than 1 in 5.
Okay. That's pretty clear. That's good. Thank you. What about endometriosis? I had people asking about the impact of endometriosis, PCOS, and should people be freezing their eggs earlier if they have conditions like that?
Endometriosis, I think it's fair to say, is an agreed medical indication for egg freezing. Mm-hmm. And that's because it is a horrible condition. It's a condition where the cells of the female pelvis act in an abnormal way and they make inflammatory deposits that can bleed every time you have a period and cause scarring inside the female pelvis. Endometriosis can also cause endometriomas, which are, we call them chocolate cysts because the inside of them look a bit like chocolate, like liquid chocolate, but they're basically inflammatory cysts on the ovary and they can destroy surrounding ovarian tissue. There's a huge spectrum in terms of how endometriosis affects people. Some people can have very mild endometriosis that isn't so serious, and other people can have really severe disease that renders them infertile. It is a progressive condition, so it gets worse over time. We do have good medical treatments for it that ultimately are contraceptive. You can't be on medicine that suppresses endometriosis and try and get pregnant at the same time.
Yeah.
And because it's progressive and because in its own right, aside from age, aside from egg number, aside from egg quality, in its own right, it's a negative prognostic factor for fertility. Women with endometriosis, can very reasonably consider egg freezing. And the younger you are when you freeze your eggs, as a general rule, the better the eggs. From an endo perspective, probably the younger you are when you freeze your eggs, the better chance you have of having a baby with those eggs, and you're fairly likely to need them.
Is there like a sweet spot with the age then, or it just depends on the person?
I think it depends on when you are diagnosed and what you're going through.
Yeah.
There'll be people with endometriosis who do get pregnant naturally. I'm not saying that you can't and that it's impossible, but because it's progressive, women are never born with severe endo, it develops. Mm-hmm. So if you're lucky enough to try and get pregnant when you're younger and your disease is not as advanced, you might be just fine.
Yeah.
But if circumstances in your life mean you weren't ready to have a baby and your endo might have been undiagnosed for a long time, that's the other thing about endometriosis. The average statistical time that it takes to get a diagnosis is 7 years. So, and look, it's one of those things you say, well, how can doctors be so hopeless? Well, look, the thing is that the symptoms are vague. Often ultrasound doesn't give us the answers, particularly earlier in the disease progress. And the only way we can really cinch the diagnosis these days is to do a surgery, which is quite invasive, that people don't just do it at the drop of a hat. So it's easy for GPs to say, well, let's give a presumed diagnosis and put you on kind of suppressive hormonal therapy. And that way, at least, hopefully it won't get worse while we're not actively trying to have a child. So quite often women don't know they have endometriosis until a little bit later in their life.
So hard. It sounds like such an awful thing to experience. And then what about PCOS?
PCOS is quite common also. So 1 in 12 Australian women will have PCOS. It's a condition that is a little bit different to endometriosis in that it's modified by different factors, that some of which are in our control. So we can't control our genetic tendencies. But women with PCOS, and the PCOS guidelines are very clear about this, first-line interventions are effective. So things like moderating weight, moderating metabolism, and that can control symptoms. And the main reason that women find it difficult to get pregnant with PCOS is ovulation dysfunction. They're not ovulating properly. If that's your only issue and we get you to ovulate, then your fertility potentially will be still quite good if you're relatively young. So in terms of egg freezing, I wouldn't say that it's as much of an indication as endometriosis is.
Also, can PCOS change? Like you said, that endometriosis is more likely to progress and get worse, but can your polycystic ovaries reduce? Like, can the number actually get better over time?
It's kind of an interesting idea. Your egg count will certainly reduce over time because that happens to everyone. And with women with PCOS, what that can mean is their ovaries go from being really polycystic and high follicle number to more normal. So in a way, it can be a bit of a gift if later in life they need fertility treatment for another reason because they can make more eggs than the average person can. The metabolic side of it, though, can get worse with age.
Okay.
So just because all of us, our metabolism is not what it is at a later age compared to when we were younger. So those risk factors for diabetes and for miscarriage related to sugar control and that kind of thing do increase with age. So it's a mixed bag, PCOS.
Yeah. That has made me think of lifestyle when you talk about weight management and things like that. How much does your lifestyle actually impact fertility, and not just for women? I'm interested to hear your thoughts on men as well.
The good thing about diet and lifestyle is we do have some kind of control over it, and we focus a lot on it because of that. It's what we call a modifiable factor. There are lots of factors that are not modifiable. And one thing I would say is that most people who have trouble getting pregnant, it's not because of their bad lifestyle choices. There are people who eat Maccas and smoke who get pregnant naturally. So, sorry, I don't want to defame Maccas.
No, but I feel like that is so frustrating for the people who are trying really hard and they're doing, you know, quote unquote, all of the right things, but they can't get pregnant. And then you see someone who is getting drunk every weekend, smoking, not really caring about their health, and then they fall pregnant really naturally. I think it's really frustrating.
It is. It's really frustrating. And so what I say is, yes, lifestyle as a general rule does impact fertility, and particularly people who have fertility problems, certain lifestyle factors can make them worse. And it is within our control and remit to optimize, which is good. But, and of course it is actually, I would say, equally, if not more important for men, because men, unlike women, are making sperm all the time. And so if they have modifiable factors for their sperm, they, you know, not sleeping well, they're not eating well, they don't have a varied diet, they may be missing micronutrients. Maybe behaviourally they're doing things that aren't good for sperm, like spas and saunas and overheating and that kind of thing. Maybe they're taking testosterone.
Is cycling also?
Cycling's always much maligned. Do you know? Well, it's more the kind of overheating idea.
Okay.
It's kind of the stereotype of the men in lycra.
Yeah.
And, you know, kind of exercising and exactly trapping everything, not cooling the testes. There was this trend for a while about icing the testes. I don't know if you heard that, but I don't know, somebody said somewhere on the internet that you should ice your testes, and then all these guys started doing it. And for anyone who's listening, you don't have to ice your testes.
Noted.
But yeah, I think
But drinking and drugs play a huge factor when it comes to sperm.
And smoking. Smoking's very bad for sperm. And the thing about smoking is that there are so many ramifications that are downstream of actually the getting pregnant part. So if you have a parent who smokes, and particularly if you have a father who smokes, as a baby, you're more likely to have asthma, you're more likely to have allergies, and you're more likely to have cot deaths.
Wow, that's awful.
So it's very serious. And if your partner gets pregnant, she's more likely to have a miscarriage.
Wow.
So smoking's really bad. So we do, and look, it's not good for you anyway. So as a general
smoking and
health,
vaping?
And vaping. It's the chemicals within the vapes that are not good. So vaping's not a get out of jail free either, although most of the research has been done on classical smoking.
Now, something that people asked about a lot, which I think is completely fair, was costs and finances. And I know that that is a big reason that a lot of people can't even consider egg freezing. Can you talk about the costs, and are there any sort of payment plans or things that people can do? Yeah.
So look, I would say you're right, because our government doesn't support egg freezing, because there's no rebate from Medicare. It's very expensive, and it is a luxury and it's a privilege to be able to do it. So I totally recognise that. It's also something that women often prioritise because it's really important to them. But it might mean that they have to make really difficult decisions about other things to be able to do it. I have some patients whose families support them in freezing their eggs because the next generation's a concern to many people who are close to my patients. But look, it is expensive, and I think often it's misportrayed in advertising, because when you look at the way different clinics advertise egg freezing, it can be that they have a flag number with an asterisk, and it's really important to know that the asterisk leaves a lot of things out. So we are very transparent at Melbourne IVF as to what is included, and so the flag will include basically what it says it does. When you have your eggs collected in a day hospital and you come in for a day procedure, the hospital bed fee is something that is in addition to the cost of the egg freezing. That's pretty much everywhere.
Yeah.
And that's charged separately by the hospital, which is external. And the drugs that your doctor will prescribe will be potentially, if they're not Medicare eligible, charged by the pharmacy where you seek to buy those medications. That's where things like using progesterone prime cycles can be good, because it is cheaper than a GnRH antagonist as a medication, as well as being oral. So we do what we can to cost mitigate.
Roughly how much are we talking though?
The modern situation right now, I would say it's probably about $8,000 all up to do an egg-free cycle.
Including the cost of medication?
Including everything.
Okay.
Including everything. If I was to pick an average, that's what it would be.
And if you wanted to or needed to get more eggs, would it cost the same the next time? If there wasn't a medical reason, it was just your choice to get more eggs?
I would say it would, with a little exception in that storage costs are probably wrapped up into that $8,000. And the storage costs are annual and are not necessarily relative to how many eggs you've collected. So if you've collected one batch and then you collect another batch, you won't be charged storage twice.
They're stored together?
Yes.
Yeah. And I think my storage fees are around $400 a year.
Yeah, about that. Yeah.
Which my partner very kindly offered to split with me, which I think is great, and I hope more partners are doing that. Because even though it was a decision that I made before we met, he sees it as something that's for our future, so he wants to split the cost. Do you see that much with, obviously you work with a lot of single women.
Yeah.
But when it comes to fertility for partners, do you talk about finances with them together, and are a lot of them splitting the costs?
Look, I don't spend so much of my time in consultations talking about finances because we've got
a lot of other things to talk about.
Well, that's it. And I more have that, like spend that time with the patients talking about the clinical and then, not to dodge the question, but I then have an accounts team member who will go through to make sure that everything's fully and transparently disclosed. In terms of the partners I see coming together, I do see partners coming together to talk about fertility quite often, actually. And they'll talk about egg freezing, they'll talk about embryo freezing. If a woman is early-ish in a relationship, or even if she's just not fully committed in a relationship, or her partner's not fully committed in a relationship, I'll always encourage her to freeze eggs over embryos, because eggs are flexible. You can use them with your current partner, you can use them with a different partner, you could use them with a donor, or if you decide not to use them, you can discard them or you can donate them. So they're very flexible. Whereas embryos, if you make embryos with somebody and you then break up, they can force you to destroy those embryos, which can be very devastating, because even though you're the one who's gone through the injections, the retrieval, they've given the sperm sample, you can't have an embryo without both parties' consent.
Yeah. And
you can't have a baby with an embryo without both parties' consent. So I actually have a patient who is currently in treatment with me, who I met, I'm going to say probably around 2017, 2018, and she was in the context of a relationship and they broke up. So she went through embryo freezing and then had to get rid of those embryos. We then froze eggs for her as a single person, and it's now that she's coming back to use them with a different partner.
Oh, that's great. But I mean, awful that she went through that. The destroying embryos would be such an emotional process.
Especially in the context of a relationship breakdown as well. It's like just icing on the cake of the pain. Yeah.
Yeah. I mean, I think, any kind of fertility issues in a relationship that then doesn't work out, it's really hard. I found it really hard. And I think that was one other thing I wanted to ask you. I think with all of the emotions that came up for me when I did the egg freezing, do you think there is a period of time you should wait post-breakup before doing it? I think for me it was close to a year. And I think that was really good because I think if I'd done it sooner, everything was still so raw and it would have been more emotional and challenging. Do you recommend waiting a little bit?
I think it's just personal.
Yeah.
Some people feel that maybe it's something they can do for themselves in the context of, kind of getting out of a relationship. I have a patient at the moment who, ended an abusive relationship where she'd had children and froze eggs because she's not currently planning to have another baby, but she doesn't want that door closed on her by her ex-partner. She doesn't want her breakup with her ex-partner to mean that she'll never be able to have another child.
Yeah.
So even though she's not sure that she wants one, she just doesn't want that to be taken away from her because of her current circumstances. And she wanted to do it straight away.
Yeah.
Because she's already over 35 and she just felt that was imperative. So I think it also depends on the age you are and how you feel about it.
Yeah, makes sense. I mean, I guess the general thing from this is there are no real rules and it is case by case and person by person. And I think there was so much coming through that I want to just give everyone in my audience a hug because I think so many people are struggling with this and there were so many vulnerable questions and specific questions about conditions they might have and what they should do. I think from that, do you have any advice for those people? I know it's hard because everybody's so different.
Well, that's it. And I think everyone deserves specific advice to their circumstances. What I hope people feel is when they come to see me that they're not pressured to freeze their eggs if they don't want to.
Yeah.
But I'd certainly encourage, if you're thinking about it and if you're worried about your own personal circumstances, seek the advice of a fertility specialist who's experienced in the area because they'll be able to, with nuance, discuss your individual parameters in a way that it's impossible to do really with any, with the respect that is due to each individual generically online.
Yeah.
Yeah. And I also really, I feel for people who Google a lot because I often have patients come and see me and they're just so stressed because they've read XYZ and half of it's not true.
A lot of doom and gloom.
Yeah.
Yeah, definitely. I still have so many more questions, but we are coming up on time. So I think I'm going to have to get you in for a part 2. I guess other than coming to see you personally, you do have your podcast, Knocked Up, so people can listen to that. Are there other resources that you would recommend for people who are thinking about egg freezing and fertility?
I would recommend checking out the Egg Freezing Australia website. It's a new website that is a project created by Melbourne IVF, IVF Australia, Queensland Fertility Group and Tas IVF, but specific to egg freezing. And it's really more of a resource. Mm-hmm. So it's an education resource and it's got a really good, it's where the egg freeze calculator we chatted about is housed.
Oh, so you can just use that yourself?
You can just use it.
Oh, cool.
And you can just have a look at it. And yes, it's general information because it doesn't take anything into account apart from age. But it'll give you a good idea of what the average woman at your age would achieve from freezing a certain number of eggs.
Which I really think helps to make a decision.
Yeah, so that's a resource. And yeah, Knocked Up, a podcast I've been doing now for 8 years.
Is it 8 years?
Yeah.
Wow. Oh
so there's literally hundreds of episodes on lots of different fertility topics.
And it's great. I've actually been on it before. That was 2 years ago now, I think. Yeah. Well, thank you so much for joining me. We actually wrap up every episode with a little segment called Oranges and Lemons, where you share your positive, which is your orange or something sweet, and your lemon is something a little bit more sour or negative. Could be today, could be the last few days.
Okay, let's have a think about it. Well, I know my lemon is that my dog, since spring was cancelled in Melbourne in this deluge of horrible rain, has peed on the carpet 3 times in my house. So that's my lemon.
Oh no. Also, I think once they start, they don't stop. Like they leave.
She's testing me. She's testing me. Yeah.
That's not a good lemon.
Yeah. Well, look, I'll tell you the orange is I had a beautiful baby come and visit me yesterday called Zoe. Shout out to Zoe in gorgeous little pink dungarees. That's my favorite part of my job is when I see my patients come back. Often it's in the context of planning another child, but where I get to see the fruit of my labours, the finished product, so to speak. And nothing gives me more joy. So that's a little bit of happiness that I get day to day in my work. Obviously, there's sadness as well. I'll have my patients that I need to call because they're not pregnant after an embryo transfer. Might be their first transfer, might be their, kind of more than first transfer when they've been trying really, really hard. I had a patient yesterday I did a pregnancy scan on, which was a really nice, beautiful scan, happy outcome. But I'd previously given that patient bad news that they didn't have any normal embryos after a round of IVF when we'd done genetic testing over 40.
Oh,
so,
wow.
It's a journey. And what I would say is that there are oranges and lemons in fertility along the way, and it's the same people who achieve the happiness that have the difficulties along the way.
Yeah.
So it's about perspective, it's about perseverance and support and belief. And most of the time we win.
Yeah. Oh, I love that. Well, I think you're going to enjoy my orange and lemon. My lemon is that my jeans are really uncomfortable and tight, but the orange is that I'm pregnant and that's why they're really tight.
Oh, I love that.
Steph doesn't know. But yeah, by the time this episode comes out, I will have shared that I'm pregnant and it's making me emotional. I'm really grateful to you for everything I went through with you. This was natural. It was a bit unexpected, but yeah, I think knowing how difficult it is for so many women and what I experienced, I didn't think that it would come easily for me. But yeah, I'm really excited and very grateful. So yeah, it's a big orange.
A big orange. I'm honoured to be present at the podcast announcement.
Yeah, thank you. And thank you so much for what you do. I think, the work that you do is incredible. And I think having experienced it firsthand, it is such a challenging, emotional thing to go through. And I think you are such a beautiful person to do it with. So this isn't a sponsored episode, but if people are listening and want someone in Melbourne, I can only say only give you the highest praise. I think you're amazing. So thank you.
Oh, thank you.
Thank you so much for listening to Tell Me More. If you enjoyed the episode, please leave us a review, share it with your friends, and follow or subscribe to the podcast. Your help in growing this community would mean so much to me.